thank you, API, the chairpersons, and my respected teachers for asking me to present on a very interesting topic, which is novel therapies in early rheumatoid arthritis, and especially in the COVID scenario. So this is the overview of my talk. So what is the natural course of rheumatoid arthritis, especially early rheumatoid? What are the relevance of early treatment? Do we need to, can we change the prognosis if we institute early treatment? Is there any optimal strategy so that we can bring the disease under control? What's the role of DMARDs? What's the role of biological therapy? And how do we use rheumatic drugs in this COVID-19 scenario? Now, let's me just kind of glide through the brief natural course of rheumatoid. There are basically a few phases. It's been kind of in the cartoon, you can see from phase A to phase F. To develop rheumatoid, you need to have a genetic background, which is mainly HLA related. So HLA, DRP1, there are more than 200 genes has been identified. More association around 20 genes like CTLA4, STAT4, PTPN22, etc. So once you have the genetic background, you need to get yourself exposed to the environmental risk factors like smoking, infections like parvovirus 19 virus, EBV virus, and especially gender, female patients are more prone to have rheumatoid. So these checkpoints, when they're met, so when you tick all the right boxes, you develop local autoimmunity, which is, suppose if you continue to, with all these checkpoints, when it's ticked, if you continue to smoke, you develop citrullination of peptides, this develop an anti-CCP antibodies in the lungs. If you have EBV virus or parvo, you have ACCP in the intestinal walls. The local autoimmunity is mainly IgA variety, which then progress to develop systemic autoimmunity, which is IgG variety. But this is the development of autoimmune disease from phase A to phase C. But at this point, patients don't develop into symptoms. Gradually, it progresses to develop into phase D when they develop joint pain, joint stiffness. It can present an palindromic stage. It can present as just lung disease, synovitis, and also at certain patients, it can involve only the lungs. There's no involvement in the joint at all. But again, in certain percentage of patients, they never develop rheumatoid arthritis. So we still don't know what's the cause and what's the kind of area of development of rheumatoid arthritis. So in phase D, you can have kind of a lot of joint pain, but there is no synovitis, which is subclinical phase, which progresses to develop phase E when we have joint swelling for the first time, which is clinical synovitis. And if it's not treated at this stage, it can develop into a quite progressive advanced rheumatoid arthritis. So if we can treat the disease and around phase D with an optimum care, then we can kind of stop the progression of the disease.
Yeah.
Am I visible? Are my slides visible?
Yes, yes.
Okay. Sorry, just got disconnected. Yeah. So these are the stages of rheumatoid arthritis. You can see in the early stage, you can have puffiness around your fingers, a bit of a synovitis around the MCPs and PIP joints. If it's not treated at this stage, it will gradually develop from intermediate rheumatoid. You can see some subluxations of the joints, quite a bit of joints swollen. And again, if it's not treated or this is not stopped at this point, it will develop chronic deforming rheumatoid arthritis. A patient have a lot of functional disability at this stage. Now, what are the definitions of early rheumatoid arthritis? From the onset of symptoms, first 3 months is called very early, which is called VERA. From first 6 months is called early rheumatoid arthritis. But if you look at the various researches, there's a lot of debate about the definition of early rheumatoid. Stretch up to 2 years, you can still consider a very early stage so that we can institute right treatment at the right time. So we have a lot of radiological studies which is going on, and we can identify disease at a very early stage. At a very early presentation, even in between phase C and phase D, which I have discussed earlier, when patients have got very subclinical symptoms, you can see at this stage, patient can have quite a bit of stiffness in the hands, but there is no synovitis, so no joint involvement. But MRI scan has found quite a bit of tendinitis around the dorsal interossei muscles or the flexor extensor tendons, which can cause significant symptoms, pain, and stiffness. Now, not only the joints which you're worried about, as a multiple systemic disease, so it includes eyes. If it's not treated, it can lead to peripheral ulcerative keratitis, cause interstitial lung disease. These are all real patients. This is a patient who presented with rheumatoid nodules ruptured, this massive hemoptysis. There's a patient with rheumatoid vasculitis, and again, there's a renal amyloid, which is also rare complications of rheumatoid arthritis. So we need to identify our patients early, and we need to institute treatment in the right time, because once the joint is damaged, once there is joint erosions, then we can reverse back to the baseline. And research has shown up to 93% of the patients can have radiological like joint erosions within first 2 years of symptoms. And if you do imaging, if you have your more suspicion, erosions can be found as early as 4 months from the onset of rheumatoid symptoms. Now, this is an example of a real life patient, 36-year-old female patient, rheumatoid arthritis, and you can see the erosion and the ulnar-styler process around around 9 months from the onset of symptoms. Now, early diagnosis is crucial. We are all used to this ACR classification criteria in our textbooks, but you can see the sensitivity and specificity of is around 30%. So then ACR EULAR has come up with a new classification criteria in 2010, which has been modified later on. So they have 4 domains like joint distribution, serology, including rheumatoid factor anti-CCP, symptom duration more than 6 weeks, and acute phase reactants like ESR-CRP. So if someone is coming to your clinic for the first time, even without your blood test, so you can still diagnose rheumatoid, because if someone is having symmetrical synovitis, he scores 5 of the joint distribution. And if the symptoms is more than 6 weeks, he or she is scoring 6, which is required for the classification for the rheumatoid arthritis. Now, this is a slide. We all use rheumatoid factor anti-CCP. The specificity of rheumatoid factor is 84% roughly. This is according to this study. There's quite a bit of variation as well. And for anti-CCP is 97%. But in combination, the specificity is around 96%. But if you look at the graph, which is in the left side of the kind of screen, 0 means the onset of symptoms. But this autoimmunity, which I have discussed earlier, this generation of anti-CCP antibodies and rheumatoid, they kind of develop 15, 20 years, previously. So if someone you see at this stage, they'll have rheumatoid factor, but they won't have rheumatoid symptoms. Again, for cases of subclinical synovitis, where patients have a lot of joint symptoms, but you can't see much of synovitis, ultrasound scan or MRI scan could be helpful to get the diagnosis right. But when you're diagnosing early rheumatoid arthritis hastily, there's always a chance of errors. So you have to be careful about rheumatoid mimics, like the infections arthritis, like viral infections, seronegative arthritis, connective tissue disease, crystal arthropathies, or like infective endocarditis, etc. Now, what is the optimal strategy? We have a lot of different medications. So what are the goals of rheumatoid arthritis? Ideally, there are few goals which has been set up. One is the clinical goals, when you can treat the joint stiffness, joint swelling, deformities, which is a clinical remission. The radiologic remission is when you can inhibit joint damage, and the functional remission when patient can go back to their normal life, their work, etc., and have a good quality of life. But the time has come. We are thinking about non-clinical remission, which is the immunological remission, that is losing the antibodies like anti-rheumatoid, anti-CCPs. Whether this is possible, this is a matter of debate. There are few biological remission markers there. There's a vector DA, which goes up before the rheumatoid flare. And again, it comes down to baseline when the joint is under remission. So these markers is still under development that might guide us to stop or start a disease-modifying therapy as early as possible. Now, rheumatoid is a chronic disease that includes multidisciplinary team management, like symptom control, disease-modifying drugs, complementary like massage, physiotherapies, rehabilitation. A lot of psychological interventions might be needed, even for, not for the patient, also for the family as well. The multiple area of drugs we have at this point in time in our therapeutic armamentarium, including conventional synthetic DMARDs like methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, azathioprine. They're a big list. And next is the biological treatment, including the anti-TNF agents, IL-6 blockers, B-similar cell blockers, co-stimulation blockers, and the JAK inhibitors. These are all expensive drugs, which is very difficult to treat for the Indian patients. So biosimilars and generic drugs, which has come, they're almost similar drug with lot lesser cost, which becomes affordable for the patient as well. Now, what is the optimal DMARD therapy? I know that my topic is novel therapy or newer drugs, but let's focus on the optimal DMARD therapy. Can we achieve good quality of remission with the standard medication drugs? Firstly, the corticosteroids. The studies have shown that oral corticosteroids or judicious use of intramuscular injections can have similar efficacy. And if steroid is used judiciously in combination with DMARDs, they can have good improved clinical and functional outcomes. And steroid plus DMARDs, when compared to DMARDs alone, can reduce or kind of stop the radiographic progression as well. Now, the reason I have put this slide, this is a busy slide, we probably need to use steroids to start with to bring the swelling and the kind of deformity or the symptoms under control, because all the DMARDs, what we normally use, they take up to a few months before they start to work properly. Now, let's focus on the few trials where combination DMARDs can really be helpful. There's a very landmark trial, COBRA trial. I'm not going in details. So they have compared sulfasalazine monotherapy with the combination drugs like sulfasalazine, methotrexate, and prednisolone. Because of time, I'm not going in the details, but the overall, the conclusion is 6 months down the line, you can see at 28 weeks, ACR 20 and 50 response is significantly better in the combination drugs. And because in this study, methotrexate was gradually stopped and steroid was gradually stopped after 6 months down the line. And having said that, the radiographic progression did not kind of resume, but stabilized at a level that was lower than that was reached in the sulfasalazine monotherapy group. So that tells me that the radiographic changes or the damages occur quite early in the disease. So if we can control them very early on, you can have a good quality of disease control. Again, this is a Finnish study. They have 199 patients. They compared monotherapy with sulfasalazine and methotrexate plus minus steroids versus combination therapy. And they have also found the 1 year and 2 year remission rate is quite significantly better, statistically significant and higher in the combination group. And again, 33% retardation of radiographic progression in the combination DMARDs group as well. Now let's come back to the biological treatment now. So this is in a nutshell about the various cytokine signaling pathways, including TNFs, interleukin-6, B-cell pathway, co-stimulation blockade. There's multiple drugs which I've mentioned in the slide before. Anti-TNF drugs like etanercept, infliximab, adalimumab, golimumab, certolizumab. Co-stimulation blocker is abatacept, tocilizumab is the IL-6 blockers, rituximab is the beta cell blocker. But having said that, you can see all these cytokines in the extracellular area and environment. After having used this drug for around more than 20, 30 years, we still haven't reached a kind of magic bullet where we can cure the disease. So the kind of concept or the focus has shifted from extracellular to the intracellular pathways, because all these cytokines are mediated through intracellular kind of kinase pathways. So various kinases have been identified, and one of the most important is the JAK kinase pathways. The reason is how JAK pathway signals. So when the cytokine binds with the cell surface receptor, the JAK kinase is activated and phosphorylated. The activated JAK then attaches STAT proteins. Now JAK-STAT pathway, kind of the complex, is translocated to the nucleus, and then there is transcription of all the cytokines. So if the JAK pathways, kind of JAK kinases, are inhibited, then we can inhibit multiple cytokines at a time. You can see this cartoon where JAK1 and JAK3 kinase, they are catering to multiple cytokines. So if you just block one pathway, you probably can inhibit multiple cytokines in one go. So when do we start biological therapy? That's a big question. There's a nice guidance, multiple guidelines by various BSR and ACR as well, but nice guides and quite easy to understand. So failure to respond or tolerate adequate therapeutic trials or standard DMARDs. And what we mean by adequate trials, a treatment of at least 6 months for at least 2 the target dose, unless the significant toxicity happens or the patient can't tolerate or they have significant side effects. Now, what is the optimal strategy? Is a DMARDs, combination DMARDs is better, or biological therapy is better? There are a few interesting trials, which is the best kind of trial. They have compared 4 groups. One group, they have added on sequential monotherapy, started with methotrexate, stopped methotrexate, and started sulfasalazine, stopped sulfasalazine, and then leflunomide. Group 2 is that kind of combination of drugs like methotrexate, and then added on sulfasalazine, then added on HCQS, and finally infliximab. Group 3, they have started on combination therapy from the very beginning. And group 4, they have used methotrexate and infliximab. And the results showed group 3 and group 4, where they have used combination therapy and biological therapy, and at the very beginning, their outcome in terms of clinical outcome, DAS28 score, HAQ score, they're significantly improved in group 3 and 4. Even the radiological progression of lesser in group 3 and 4 as well. This is also an interesting study, especially in Indian subcontinent, because we are quite focused on biological therapy. But this study has shown if you use kind of combination DMARDs like methotrexate, sulfasalazine, and hydroxychloroquine properly, and this study has also compared etanercept and methotrexate combination therapy, and they have found that the triple therapy is non-inferior to the combination DMARDs therapy. So although biological treatment is definitely better than DMARDs, but if you use, especially when cost is a major restraint in Indian subcontinent, if you use combination DMARDs properly, you can still bring early rheumatoid patients under good control. Now, what is the optimal biological therapy? There's multiple trials. So TEMPO trial has showed methotrexate plus etanercept combination therapy is better than methotrexate monotherapy, monotherapy and etanercept monotherapy. Again, COMET trial has showed biological therapy in combination with methotrexate have significant improved radiological outcomes. The multiple drugs has been tested, multiple agents has been tested. These are all landmark trials, and they have all found biological anti-TNF agents when used with combination or as a monotherapy. They have done much better with in compared to either placebo or methotrexate monotherapy. So in a nutshell, biological therapy is definitely better, but we shouldn't ignore our basic standard, which is a kind of standard DMARDs, synthetic DMARDs. Now there are trials which has compared anti-TNF therapy with rituximab. I'm not going in details because of the time. The rituximab efficacy was non-inferior, and the compliance rate was much better in rituximab group, and cost is much lower. So basically, Indian patients probably will much be benefited with rituximab patients in company anti-TNF. But the crux is in this COVID scenario, rituximab is probably need to be avoided. The risk of COVID infection is much higher. Now let's come to the IL-6 blockers. Tocilizumab is EUACT early trial. They have compared tocilizumab with, they have found that tocilizumab with or without methotrexate is more effective and more safe compared to the standard methotrexate treatment. Again, sarilumab is a new drug which is coming in a big way, and this study, MONARCH study, has compared sarilumab with adalimumab. And this study is showing very promising results, and the results are showing that sarilumab is probably more efficacious than adalimumab in terms of disease control, improved physical function, and radiological progression. Now let's come to the JAK inhibitors. There's multiple drugs which has been approved, like tofacitinib, baricitinib, is all been approved by FDA and EMA, and filgotinib and upadacitinib is coming in a big way. Results are quite strong. You can see tofacitinib not only by just JAK inhibition, it can block multiple interleukins or kind of cytokines, and these are the, I've already mentioned that. Now, if you look at the tofacitinib study, they have compared with the adalimumab oral strategy study, and they have found that tofacitinib in combination with methotrexate is non-inferior to adalimumab combination therapy. Same as with the RA-BEAM study, which is 4 milligram daily. They have also found RA-BEAM baricitinib is significantly better, not better, probably same or non-inferior to adalimumab therapy. Now, this is in a nutshell what we have various novel therapies. Multiple drugs are still coming up there in the pipeline, but it's difficult to discuss all of them in the one go. Now, let's talk how should we treat our patients in this COVID scenario. So we have seen many patients, their family physicians are asking them to stop their DMARDs, and especially SLE patients, rheumatoid patients. The patients are coming back to us with a massive flare because their own doctors have asked them to stop the medications. So my suggestion will be, please don't stop the medications. Let them continue the medications if there's not been infected with COVID, but use judicious doses. If its disease is reasonably under control, you can bring or lower the doses at some point. But if they are positive for COVID and if they have severe symptoms, probably need to stop on medications. They need to speak to the rheumatologist as soon as possible. But we need to follow the basics like use of sanitizer, mask, and social distancing. And patients are all sedentary under lockdown at home, so they need to follow regular exercises as well. Now, these are the American College of Rheumatology guidelines about how to use DMARDs and how to use the vaccinations, which I'm going in a nutshell quickly. So if someone is ongoing treatment of stable patients in absence of any infections, you don't have to stop any medications. Even for SLE patients who are pregnant, we need to continue with HCQS without stopping them. Now, if someone is having ongoing treatment of stable patients following SARS-CoV exposure without any symptoms related to COVID, then HCQS, sulfasalazine, and anti-inflammatories may be continued. Immunosuppressants like methotrexate, non-IL-6 blockers, because tocilizumab is used for COVID infection. JAK inhibitors should be stopped temporarily for 1 or 2 weeks, depending on how quickly patient recovers well. If patient is having documented or presumptive COVID infection, then regardless of COVID-19 severity, anti-malarial HCQs should be continued, and immunosuppressives should be stopped, again, for a kind of not prolonged period till the patient recovers well. And for when to start the patient, start the treatment. So when basically for patients with uncomplicated COVID infections, you can restart in 4 to 10 days. And for patients who have been tested positive for SARS, because it might take a long while to take the kind of test negative. So if the patient remains asymptomatic and doing really well, you can restart treatment after 10 to 17 days. Now, how about vaccination? So there's a debate which vaccine to go ahead, whether it's Covishield or Covaxin. So Covishield is a kind of includes the spike protein, whereas Covaxin includes the dead virus. So there is some thoughts that Covishield is probably better for patients who are on immunosuppressive agents, but there is a controversy likewise as well. But every patient should be vaccinated. We shouldn't ask or withhold some patients because they are on immunosuppressive drugs. As they are having immunosuppressive state, they are at higher risk of having infections anyway. This is again the ACR guidelines for vaccinations, which drugs to stop and which drugs they can continue during the vaccinations. For regular DMARDs like hydroxychloroquine, apremilast, steroids less than 20 milligrams, patient can go ahead with the vaccination and then have to stop any medication. If they are on DMARDs like sulfasalazine, leflunomide, mycophenolate, azathioprine, again steroids, low dose less than 20 milligrams, they can have the vaccination. You don't have to stop the medications. If they are on methotrexate, they should be asked to stop methotrexate 1 week after the vaccination. But again, there is a debate about it, whether that will make any significant difference. If someone on JAK inhibitors, they have to stop the drugs for 7 days after the vaccination. Abatacept, we don't have it in India, so I'm not discussing. Cyclophosphamide infusions, they are probably life-saving drugs. They have to be given, but you have to kind of time the infusions at least 1 week after the vaccinations. For rituximab, all this is
please wind up, Dr. Das. Please wind up.
I'm just finished last slide, sir.
Thank you.
And for rituximab, probably we have to stop the kind of have the infusion at least 1 month after the vaccination, or have finished the vaccination and then start rituximab. So just take home message. So early diagnosis and treatment to remission is important. So judicious use of biological therapy needs to be taken into consideration for optimum control of disease activity. Multidisciplinary input is needed, including rheumatologists, physiotherapists, orthopedics, but we shouldn't forget to address the cardiovascular implications. Thank you very much. I'm extremely sorry for the inconvenience caused and the time extra taken for the kind of loss of connections. Thank you.